Welcome everyone. Here we are in Boma session. The next session is Boma, Kenya. We're here with Victoria. Welcome, Victoria. Thank you for attending. She will take the lead now. So it's up to you, Victoria.
Wonderful. Thank you so much, Marconi. And a great session there with Anahita. Welcome everyone to the Boma, Kenya session. And as Marconi said, I'm Victoria Rubadiri. I'll be moderating this session. I'm really excited about this particular topic. It's something that's very personal to me. Mental illness, Africa's silent epidemic. So now when we talk about health or disease, especially in Africa, it's been more from the perspective of medical response, and focus has been primarily on infectious disease. Now, for a long time, mental illness has been ignored or disregarded as just not serious enough. Now, there's the issue of stigma as well. Culturally, having a mental illness is frowned upon in most African countries and cultures, and some are even deemed as being cursed. Many have had to suffer in silence as a result of this because of fear of disclosing their mental illness and being ostracized as a result. There hasn't been enough focus on setting up a robust mental health care system, let alone funding to this segment of healthcare. African governments are waking up to this invisible and silent epidemic, and that's exactly what we're talking about in this particular session. What more needs to be done? What's the current state of mental health care here in Kenya, and what are some of the solutions? Let me quickly introduce my panelists for this particular session. First is Dominic Kamau Mwangi. He was the Dean of Students at Tangaza University College and is currently a lecturer in psychology at the same university that's based right here in Nairobi, Kenya. He's currently a doctoral student of psychology and board member of the Positive Psychology Association of Kenya. He holds other degrees in philosophy and in education, and is also a professional speaker, a leadership trainer, as well as author of 2 motivational and psychological support books. Next, we have Dr. Githinji Gitahi. He is the Amref Health Africa Global Chief Executive Officer. He's also the co-chair of the UHC 2030 Steering Committee, a global World Bank and World Health Organization initiative for universal health coverage. Dr. Gitahi is a member of the board of directors of the Standard Group in Kenya, and was recently appointed as a member of the board of trustees of Safaricom Foundation. He's also a member of the governing board of the Africa Centers for Disease Control and Prevention, Africa CDC. And next we have Moitree Sinha. She's a humanitarian, a social entrepreneur, scientist, and seeker. She's also the CEO and founder of Cities Rise. And that's a platform that brings together international and national leaders in mental health to drive a new level of progress through its networks, its experience and expertise as well. Moitree has a PhD in physics, and among the plethora of accolades she has received, she was bestowed with the Kingdom of Cambodia's highest award for philanthropy. Thank you all for joining me on this session. Let's jump right into it, Dominic. And for those who are watching who don't really have an understanding of what the mental health landscape is like in Kenya, and are just curious about what it's like to deal and grapple with a mental illness in this country, just paint that picture for us.
So yeah, the landscape, first of all, the mental health in Kenya is quite, it's not something that is admirable, I have to say. First of all, we are not ranking very well in the best things, if I might say. In terms of mental health, Kenya is ranked as the 4th in terms of having the highest population of mental health, people with mental health issues, mental illnesses. And number 6 in terms of depression alone, in terms of from the African perspective. So out of the 54 countries, we are among the top who are not doing so well in terms of the issue of mental illness. And the World Health Organization says that our population is around 4.7 million of the population has some sort of mental illness. That is at 10.3, that is as of 2016. So I'm imagining this can only have increased because we do not know, unless there are some issues that we can say there could have been positive reasons for us to say there's a reduction in terms of mental health issues. There is a very good chance that maybe we are at 11% more than there is that we are at 9%. So which are some of the most common mental health issues? The most common is depression and substance abuse, followed by stress and anxiety. These are some of the most common related illnesses that are there. And the World Health Organization, the Kenya National Commission of Human Rights also says that up to 42% of people who go for primary health care, who go to hospitals, they have severe, at least up to severe depression. And that's a very, very high number. Up to 42% of Kenyans who go to hospitals have psychosomatic illnesses, if you want to say that. That would be a good term to help us understand what we mean by here. So now, one of the problems in Kenya is we have very poor data collection. There is very poor data collection in terms of how many people are sick, primarily because there is the problem of reporting, and also there's a problem of the fact that the government has not invested a lot in terms of the infrastructure dealing with mental health issues. And take, for example, in a country of 47 million people, we have 88 to 92 psychiatrists. That means one psychiatrist is helping almost 500,000 people. That is not manageable. And because of that, because of this lack of awareness, because of this lack of investment in mental health care, we have an increased number of domestic violence and homicide and suicide every other time on the news. And this is what I would tend to say in answer to this question, that I think, now as a psychologist, I know that someone who has been affected by an experience, let's say when they were 10 years, 5 years, 6 years, affects them even when they are 60. Kenya is 57 years old. Therefore, we need to talk about psychological trauma that is historical. So we have never spoken about the psychological consequences of colonialism because maybe we think it's past us, but it is there. My father was part of people who suffered because of colonialism at the age, he is 80 years old, and he tells me of the suffering he went through when he was younger, when Kenya was still under colonial. So it is still there. And so there are historical causes. There are historical causes within the time that the Kenya was a nation. Talk of the post-election violence. There are consequences to that. So there are cumulative traumas that are there that I think we need to talk about, and to understand, therefore, that there are structural issues that we will be conversing that contribute to this situation.
Absolutely. There's an interesting angle that you introduced when it comes to trauma from the colonial period. And of course, we're talking about the current state in terms of a pandemic and the kind of impact that's going to have. We'll talk about that later. Dr. Githinji, let me bring you in, because when we talk about how our healthcare system is structured in terms of responding to mental health care in Kenya, for people just to have a general look into how it's organized and what kind of problems do patients face, particularly those with mental illness, when it comes to accessing that particular healthcare in Kenya.
Thank you, Victoria, and thanks, Dominic, for that overview. The challenges we have in terms of how mental health is integrated into the health system. To understand the Kenya health system, and probably it will be similar to many other health systems in Africa, the first thing is to understand that the definition of the health system as defined by WHO is kind of very supply driven. It is about the government supplying healthcare to the people. It hasn't been able to be redefined to capture people's participation and people's central role in it. It's more about health workers, facilities, yet we know that health is made at home and in the communities, and that's where actually health is made and that's where it's maintained. And the facilities, which we call the health system, are more or less just what a friend of mine likes to call garages for repair, for when you are actually unwell. The real issue is that the health system is created to respond to disease. It's not created to, it's not kind of built up to maintain or to build health. It is built to respond to disease. Now, which then speaks to the fact that if you look at the health system as defined, you'll be looking at the facilities, which starts all the way from level 6, which is the most tertiary hospital, coming down. And mental health in the old days, including in the initial Mental Health Act, and I'm sure Dominic will probably be more conversant with this, was defined as medical, as a curative issue that was supposed to be cured People had no right to choose whether they are cured or not because they were seen as people who are disturbing society, and therefore even voluntary treatment was only more recently kind of discussed. So if you then look at that, you would find that the majority of people, as Dominic has talked about, who have mental health illness that actually they don't know they have, and therefore they don't, if you have a wound, you know you need to seek care, you go to the hospital. If you're pregnant, you need to deliver, it's easy for you to go to the hospital. Majority of the people who have mental health illness may not know they have it. They think it's normal. You talked about stigma. They do not know they need to seek care. So the health system, which is built to wait for people who believe they're sick, is therefore not built to prevent or to promote good mental health. That's the main challenge. Now, this also speaks to the lack of integration of mental health into the basic health packages. If you look at, for example, even community health strategy and the training of community health workers who are really, really key in integrating community ownership in mental health services, the package on mental health doesn't occur, it doesn't appear. It is more modules on malaria, HIV, TB, there are modules on infection control, there are modules on maternal health and child health. Mental health is not a module that is trained to community health workers who are so key in creating preventive and promotive services for mental health. If you look at that, just that tells you that actually the entire mental health aspect is built as a curative side. In fact, if you look at many of the countries, including Kenya, we had a mental health hospital. Kind of, instead of integrating mental health into services, it is seen as something you need to treat separately. And yet, it is something that should be integrated, because if you look at anyone who is coming to the health sector, and I think there are statistics that show that majority of the people, no, not majority, a significant number, maybe up to 25% of people coming to an outpatient clinic, have mental health needs. So that's what I'll talk about. The challenges are integration, and also the fact that the health system is built to respond to disease rather than to create health. So those are the things that I would like to highlight.
Really interesting point you raised on how our system is structured to respond to disease as opposed to health building. And I wonder, Dominic, from where you sit as a psychologist, how does this, if at all, impact how you respond? Do you find some psychologists, counselors, those who play in the mental health space, are trained in a way that they respond to a disease as opposed to maybe helping someone manage and maybe, someone get over it in some shape or form? How does that affect how you respond to those with a mental illness?
Yeah, thank you so much. There is actually, from what Dr. Githinji has mentioned, something quite interesting also in the history of psychology, or the movement in psychology, that psychology was for a long time focusing on the curing aspect, and then it moved to actually the preventive aspect, and then it's now moving towards promoting. Okay, so instead of simply curing, we are not talking also of preventing mental illness of happening, but also talking about how to actually promote the current positive the well-being of people. And that's where positive psychology actually came in. That for a long time, psychology was dealing with what is wrong with people. And then positive psychology came and said, why don't we deal with what is right in people and promote that, and prevent them from getting into the mental health issues in the first place. So indeed, it is true that the model that Dr. Githinji has mentioned is actually also impactful within the framework. And now there is a new movement within positive psychology of seeing how people can have positive frameworks of dealing with evil, because we cannot simply focus on what is right in people. We must also look at how people integrate the question of evil and suffering and tragedy in their lives. Yes.
And really quickly, Dominic, if you can speak to and probably give us specific examples of what stigma looks like for people dealing with mental illness in this country. I alluded to one where people say, I could be cursed if I have a mental illness. There's also the religious, the social aspects that come with having a mental illness in this country. So just for people to understand what it actually means.
Yeah, there was this author who said that Africans are inherently religious, and they tend to interpret a lot of their experiences in terms of religious terms. Let me give an example. 9 years ago, CNN ran documentary concerning our top mental health hospital, Mathari Hospital. And they came up with this documentary called Locked Up and Forgotten. And there they saw how communities and families have dumped people suffering with mental illnesses there. And those people are tied up in chains, a number of them. Some of them are sexually abused by other patients, and some of them die as a result of the violence from other patients and the unsanitary condition that were there in 2011 when they ran that documentary. Of course, now the Kenya National Commission of Human Rights came in very strongly and criticized that situation. And because of that, it improved. But you can see that the reason that it was improved is not because there was a positive motivation towards that direction. It was because that they had been exposed. Just last year, a 12-year-old girl committed suicide because a teacher made fun of her and criticized her in front of her students because she was experiencing her menses and she had not she didn't have the tampons or she didn't have the sanitary towels that they're required to have. So you can see that this caused a lot of pain to her and to the family. And what happened was justice. Now, justice dealt with the teacher, but did justice deal with the mental health issues that the kid, the family that was left behind was still dealing with? Did it empower other teachers on how to actually accompany students like that? So there is that aspect. Now, some of the things that you have to go through if you are someone grappling with mental illness in Kenya or in Africa in general is cultural. And the cultural part is in two ways. The first part is mental health is not part of our lexicon. It's not part of how we speak. I am feeling stressed, let me go and see a counselor. It's not part of what we say. It is not part of what is commonly spoken as common language. But also the deeper part is the cultural part. So as I've mentioned, there is a strong association of mental illness with spiritual problems. And this is where now, instead of actually going to see a counselor, someone who is suffering from a mental illness chooses to pray about it or to go and see a pastor who prays over that person. But you see, every wound deserves its own doctor. You know, a physical wound, you don't go to a counseling psychologist, you go to a medical doctor. Same thing, a spiritual wound, you don't go to a counseling psychologist, you go to maybe your pastor or something like that. But same thing to psychological and emotional issues, you go to a psychologist, psychiatrist. So this distinction is really, really very important. So there is that kind of stigma. Now, other question is also among us psychologists, I think we have a certain fear of using a biomedical approach that is not too Western, such that we alienate the people by using a language they do not understand. Now, unfortunately or fortunately, the primary language of many of our patients is religious. Whether or not they're using the word God, they use the idea of good and evil when they are talking about the mental health issues. So a psychologist who is taking care of people in Africa, in so many of the parts of Africa, has to use a lexicon, a language that they can actually understand. And I want here to appreciate the Ministry of Health that has been training volunteers at the rural level to actually accompany people with mental health issues at a low cost, and take into consideration their beliefs and cultural practices. And this approach actually has been approved by the World Health Organization as something that is unique. And now, the next part is the poor accompaniment. When parents bring me their children, talk to my son, talk to my teenage daughter, they also come back and they want to tell me, so Dominic, what did you tell? What did my daughter tell you? And I'm like, I cannot do that. I cannot tell you what is happening. And when they go home, they start pestering the teenager. What did you tell the counseling psychologist? Why can't you tell me that? And so this creates distance. So the question of people listening seems to me to be something that we need to train people to actually listen in order to accompany people dealing with mental health illnesses.
Dr. Gitahi, I wanted you to kind of speak more to the issue of how mental health care has not been integrated into primary health care as we speak. Now, until we get there, right now we have Mathari Hospital, which Dominic talked about, the only psychiatric hospital in Kenya. It also serves as a referral hospital for the rest of the region, grossly underfunded. And right now, that's all we have to deal with. How do we boost its capacity until we get to a better and more integrated system when it comes to dealing with mental health care in this country?
So I would like to highlight two things, Victoria. One is I would just like to reflect on something Dominic has said about stigma. When I grew up in central Kenya. I grew up knowing that anyone who had a mental health problem was called a mad person. Now, up to now, people in the rural areas, when they see somebody who has mental health illness, they say they're mad or insane. Those two terminologies are used a lot. And that is where the stigma starts. So we grew up knowing mad people are bad people. And that's, and it's also because of what we talked about, that care was largely pharmaceutical driven. It is people who had severe mental disease who are then arrested by force, and they were taken into the Mathare mental hospital, Mathare mental hospital. And therefore, it was more of a medical approach, and also left people kind of with an image of who somebody with a mental illness is. It was, you could see it. You could actually say who the mad person was. And we still use the terminology, every market has a madman or mad woman. It is a highly stigmatizing statement. You know, we just use it as if it's normal lingo. But those people, when you walk back, those people are called madman or mad in the marketplace. So when we look at that, then let's come back to your question regarding Mathare Hospital. Now, if you look at mental health services, it's only a tip of the iceberg of the people who need inpatient services. So if we look at mental health services in Kenya and we see Mathare Mental Hospital, then we're only seeing a small number of people who need maybe inpatient or biopharmaceutical care. But we need to think about, beyond the provision of the budget allocation to Mathare Mental Hospital, what processes, what access mechanisms exist for somebody who visits their local health center as level 3, who goes to their local dispensary with anxiety disorder, who goes to the health center and finds a nurse and they have depressive condition, and maybe they don't know, they're just feeling suicidal, they're feeling this and that. What does the nurse do? What happens? What is the mechanism for that person? Does the nurse refer? Does the nurse give painkillers? What does the nurse do? And that is where we have actually failed. Now, the integration of expanding mental health services was done at some time ago, I think in 1989 or so, and also in the current mental health policy, which talks about integrating mental health services in the health system rather than seeing it as a vertical. And what happens is that many of the, beyond Mathare, actually the Act provided for designation of other hospitals as mental hospitals, so that you just go away from looking at Mathare Hospital, so that any other hospital can be designated as a mental care hospital. I think the challenge has been in moving forward with that, and the challenges have been several. So let me say some of them have been, if you look at the Kenya Essential Package of Health, it does provide for mental health services as an essential package for health. But if you are then to go, and maybe Dominic has done this, and you go to a dispensary and you ask, what do you have? If somebody has anxiety or depressive disorder, what do you do? Are there protocols, for example, for the nurses to follow, that if you find these symptoms, this is what you're supposed to do? If you went to a level 2, which is a dispensary, or you went to a level 3, which is a health center, you will probably find very clear protocol and clinical guidelines for management of TB or for management of HIV, exactly what to do. If you find a child with measles, exactly what to do. But will you find a similar guideline on what to do if you find somebody with anxiety disorder? Or is there even a guideline that is actually at that level? This is the integration we are talking about. So if you look in the past, before we started talking about universal health coverage, what we had was a situation where we are asking for money for every condition. We are asking for money for HIV. We are asking for more financing for hypertension, more financing for diabetes. And we started to have this kind of language where you say there can never be universal health coverage without diabetes. There can never be universal health coverage without hypertension. And now we are flipping that discussion and saying there can never be good diabetic care without universal health coverage. There can never be good hypertensive care without universal health coverage. And there can never be good mental health services without universal health coverage. Because universal health coverage speaks about integration of all essential services for everybody without financial difficulty, meaning that somebody who has mental health illness should not have to worry about access to Mathare Hospital. They should be able to worry about, I am an individual who has a health need, and therefore when I go to my primary healthcare center, which is near where I live, near where I work, I'll get the services I need, whether they are mental health services, or I have a cough, or I am pregnant and therefore I need care, I should find those services. And the revenue or the financing for this package of care should be coherent, should be serving, at a primary health care should serve the individual holistically. And that is where now we talk about financing being people-centered, not being disease-centered, should be people-centered, which is where we are moving towards with universal health coverage. And I know there are a lot of conversations around what we call the health benefit package, which should be financed. It should be holistic. The people with mental illness should not have to go to the streets to demand for money for mental health. They should be provided for in the comprehensive benefit package. So this is what I would say about your question, Victoria.
If we can go back to the personal element, going back to the individual, and Dominic, this dealing with something that Dr. Gitahi had mentioned earlier, that some people don't even know that they're going through a mental disorder or mental illness. They have no idea how to even identify what it is they're going through. And there's a question here that we just got online from someone saying, with quarantine confinement, do you think people are more aware of their own mental health situation? And is there a way to know? So in a sense, you're almost self-diagnosing before you go to the expert to tell you this is what you're dealing with.
Yeah, so that's an interesting question. And I think actually one of the biggest problem we have about mental health awareness is that people don't know that they have a mental health issue. Like there are many people who tell you, when I have malaria or I have the flu, I feel this way, and therefore I know I have that kind of somatic illness. But when it comes to mental health issues, that becomes a problem. Now, there is the danger of self-diagnosis, and that is a scary part that I would be afraid of going that line, that people can, you can go on Google and find out on different, and Google out, see, okay, I'm feeling this way, because it's a very good chance that you might end up Googling a headache and only maybe some site to pop up and tell you have maybe a trauma in the head, or you have a growth in the head, and that's not the case. So it's a bit scary to say that. Now, I think what we can do in this point is, and maybe I should have prepared better for this, is in terms of pointing out to proper sites that people can look into in terms of health awareness. But for now, I can encourage people to visit a site like American Psychological Association. That website, you will find the different conditions and some of the signs and symptoms that you could find. We are also, developing our own website as Positive Psychological Association of Kenya, and that could we also give links there on some of the proper and defensible websites that you can use, and you can maybe go and read out some of the issues that are there. But I would be very, very careful that you do not self-diagnose and say, okay, I think I have manic depression, or I have a generalized anxiety disorder. It's because there's a lot of overlapping. There's a lot of timelines that clinical psychology will tell you for how long you should be experiencing this. Many of these psychological illnesses, for them to be termed as a clinical condition, maybe you're actually maybe supposed to experience them from maybe sometimes 2 weeks to as long as 6 months for you to say that you're clinically sick, if you want to say. So for now, let me point you out to American Psychological Association as a website to start with, that I think is credible and can help people out. And at this point, let me point out something here, that one of the challenges that we have in Kenya is because of lack of regulations in terms of who is a professional psychologist or professional counselor. There are very many quacks and wannabes who are out there and who are ready to listen to you, but they do not have the skills, or they have some ways of thinking that they impose on their clients, sometimes making the situation even worse. So their framework of thinking, their ideology, their philosophy of thinking, and they impose that on their clients, making the situation even worse. So we need to take care, to think strongly about that. And at the same time, I understand that sometimes many people tend to prioritize the question of survival and seeking mental illness. Okay, let's say I have 2,000 shillings and one session of counseling is 2,000. Will I go for a counseling session, or will I go for to look for a meal? So I think just to expand on the previous question and answer that question from the viewer who has just come in.
And just as a follow-up to that, because and not to self-diagnose, I know you've said that that's not the right thing to do, but are there any symptoms, anything that would probably prod someone to think, I probably need to get some professional help? What are some things to look out for in terms of signs?
Okay. So first of all, if you are going through something serious, something traumatic, or something difficult, there is a change in your life. Maybe there's a relationship that that you have lost, someone has died, you have lost a job. Okay, so that these are at least some of the things that you need to point to listen to. Have you had some experience that you could consider difficult, or actually it's difficult? Maybe someone sexually abused in some form. Don't say that those negative experiences that you've just dealt with are nothing. Okay, so don't. That is a form of self-diagnosis, which is not actually proper. So if you have gone through a significant change in your life that is negatively oriented, that's already a good point where you need to see actually a counseling psychologist to evaluate where you are at. Something else you could point out is, are you experiencing, maybe take for example, you are having loss of sleep. Okay, either you're sleeping too much or you're struggling to get sleep. So this could be a condition of mental illness. People who have depression struggle with sleep, either sometimes too much sleep or not enough sleep. Something else is too much appetite or lack of it. Okay, so that could be an issue that you could look into. So these are some simple signs that you can find out. And others include that you want to withdraw to your own house. You don't want to with people. You are a people person. You're not an introvert. But suddenly you find the need to simply withdraw to yourself. You have lost interest in the daily things that you used to do. You used to be maybe to be a journalist, or even you, let's say in this, I use your example, Victoria, and suddenly you have complete loss of interest in that which you are doing every day. The things that used to interest you every day do not interest you anymore. The people that you used to hang out with, you do not want to be with those people anymore. So these are some symptoms that you can actually look to and say, okay, there's something here that I need to take consideration of. Maybe you have lost that sense of meaning in life, and this could be seen in your prayer life or in your spiritual life, in your engagement with something beyond you in terms of meaning and purpose. So these could be signs and symptoms that could help you understand that maybe here there is something at play. Another thing that people ignore is increase in temper. You are increasingly irritable. Simple things that never used to irritate you before, now someone does it and you are so angry and you don't want to talk about it, or you are, small things that you are like really blowing steam for like 2 days. So these are some good signs that maybe some people who might be experiencing this could take as a consideration.
Right. And Dr. Gitahi, let's move to response, because you mentioned, okay, infrastructure problem, personnel gap. We don't have enough psychiatrists and psychologists in this country. And there's a question here, which I guess moves into the digital health, telehealth space. And they say an idea for an app or an artificial intelligent agent that could identify and would be of help to those who probably can't physically go to a clinic or to a professional for help, because we have a massive problem when it comes to the number of psychiatrists or psychologists in this country. How do we use technology, for instance, to fill that gap of personnel?
Yeah, good question. And I would like to say that technology can both be an enabler and a disabler. And when we use technology, we must always remember that technology does not serve everyone. We have a massive number of people who cannot access apps, cannot access data, cannot access internet because of their socioeconomic position, or because they simply are not literate enough to use technology. So when we use technology, we need to remember that it enables a lot of overcoming many barriers, but we also need to always be very cautious about equity around that. So on the enabling side, I would say yes. We have many apps that are using artificial intelligence that can actually help you not only diagnose mental illness, but many others, and they ask you a series of questions. But I think what Dominic made a point of is that it's also very, very important to rely on a professional, because what normally happens is when you provide these apps or AI without backup, then you may end up people self-medicating. And especially because mental illness has a very high level of stigma, people may choose not to see a healthcare professional and to get a diagnosis. And therefore, if there's an easy way out, it's easier to use the easy way out than to actually get help. So we would like to say that, and personally, I would like to say technology can definitely assist us, but we must always remember it is halfway house because it can disenfranchise a lot of people who have no access. It can be a cause of inequity. And finally, it can also be, there are also risks of self-medication and therefore the dangers that go with self-medication. So that would be my response. But technology is definitely a way to go and to start to study and to observe as we go into the future.
And if we're to go that route of, individuals ideally going to a professional for help and diagnosis, you're also looking at a scenario where people would require health insurance or health coverage of some sort, because in terms of treatment, it gets quite expensive. And even in terms of some of the, the sessions that they go for when it comes to counseling, it does rack up in terms of the cost. And when you look at the stats in Kenya, 1 in 5 Kenyans have health insurance, which means millions, 36 million or so, do not have access to health services because they don't have health insurance coverage. How do you deal with that, structural issue?
This is back to the question around social justice. I like to always say that the opposite of poverty is not wealth. The opposite of poverty is justice. That actually no one should be poor if there was justice, because the social welfare state, social welfare and redistribution mechanisms, tax, which is a social justice issue, comes. Now, in situations or in communities where therefore justice is absent and people have to worry about basic services like health, the only way to overcome that is for publicly driven agenda to ensure that everyone has access to universal health coverage, which is a basic right. Health is a basic right, and people should be able to have their basic rights. And I like to say also that health is the most fundamental human right, because without it, you can't access the others. If there's no need of telling you that you're going to access education if you don't have health. Healthy children learn, healthy adults earn. So the first thing I need to give you for you to be able to enjoy other rights is health. So to your question, there's no shortcut to overcoming that challenge other than achieving universal health coverage that is publicly driven, tax funded, and an equalizer of everyone. And that is the baseline. There's no other way out.
Dominic, let me bring you in and just kind of going back to stigma, because when we talk about individuals who probably would not want to seek out help because they don't want to be identified as someone dealing with a mental health illness or mental illness, for the fact of what Dr. Gitahi talked about, being a madman or mad woman, if you will, you're dealing with a segment of people who are in denial. So they may sense something is wrong, but they don't want to go to seek help because of being tagged as a mentally ill individual. How do you start to break down the stigma, for someone who doesn't want to put themselves in that category for obvious reasons?
I think one of the things that we do across many, it's like in a business. If you want people who follow you to perform well, you have to model the behavior that you'd like them to see or to exhibit. So I think the only way that we can do here is to actually demystify the issue by actually celebrating and bringing forward people who take advantage of it. I have gone for counseling myself. I'm a counseling psychologist, and I have gone to see a counselor very, very many times when I was struggling. I've gone up to more than 20 sessions to a counseling psychologist. So being able to say, maybe saying something like this, and I'm a psychologist, could help someone out there to realize that there is nothing wrong with that. And I like that statement that Dr. Githinji made in terms of, in our language, and I believe we share the same language with Dr. Githinji, that someone who has a mental illness is called modoina goma, someone who is mad. And not only mad, but modoina goma in Kikuyu could also mean possession, someone who is actually possessed by demons, right? So it's a serious stigmatization, that's what you have to say. Now, I think for me, the best thing that we can do is to bring out, first of all, of course, build awareness, but also to bring out people that have actually gone for therapy, and for people to see this person went for therapy and there's nothing wrong with it, and they are actually very prominent. They may be functioning very well. They are actually very, very happy. So it is, I think, I don't know of another way other than creating awareness and campaigning, but above all, modeling and showcasing to people that in fact mental health care is health care, and it is actually something very, very normal to go to. That is what I have in mind at the moment.
I want to throw a statistic at you. There's from a 2014 WHO report that was looking at the suicide rate in Kenya, and showing how much of a burden men carry, and their rate is 3 times higher than that of women. You know, and we know for obvious reasons, socially, men just do not talk about their feelings, do not talk about their struggles, and bear that on their own, and many times leading to suicidal rates that we're seeing now. What more do you think could be contributing to that, and how are professionals trying to find ways of reaching that segment of society?
I think one of the things that we need to hear here is the fact that more women have mental health issues. It's that the question of suicide is the one that becomes a distinguishing factor. So notice that more women attempt suicide, but actually more men commit suicide. So I think we need to differentiate on this. That whereas women, oftentimes when a woman is trying to commit suicide, oftentimes they will use a method that is reversible. Let's say they will swallow drugs or something that is reversible in the course, if you want to say in the course of committing suicide. So the reason that more men commit suicide is because they tend to use irreversible methods. They jump off houses, they shoot themselves, they hang themselves. So they use irreversible measures. It's not that they have higher levels of mental illnesses. So this distinction is very, very important, so that people can understand. So women actually score higher when it comes to neuroticism, okay, which is the measure of mental illnesses from a personality perspective. But still, going back to your question, is we do have a cultural problem, and it's not limited to Africa. It's limited to the question that a man, from an evolutionary psychological point of view, is wired to be territorial, to be the person who is in charge, to be the one who shows leadership on, is the one in control. Now, when a man is not in control, that becomes a bit of a problem for many men wherever they find themselves. And there's a strong relationship between violence and poverty levels in any country. And it's called the Gini coefficient. The Gini coefficient shows that when it's too high, then the levels of violence are quite high. And what does this mean? That oftentimes when men, especially, who are the one who promote violence because of the fact that they are men. So we're talking about the higher levels of testosterone, and we're talking about the higher levels of disagreement. Because of that fact, by the fact of being men, the chances of committing violence is higher, all right? And that's why they end up more also in prison, in addition to the fact that many of them are growing in places where they don't have fathers. So we need to understand that the dynamic through which men also operate is where that if the economic hardship, more men will engage in violence or in other antisocial behaviors, and these other antisocial behaviors will lead also to mental illnesses, in addition, as I've mentioned, to growing up in broken family settings. So what we are trying to do is at least try to reach out to this kind of situation and help men from the time that they were young to have psychosocial skills. In my church, the Catholic Church, at least in the Church of Nairobi, and to give an example, we have a Beacon Boys program. And one of the things that we do for them is to help boys. This is actually directed primarily to boys, to empower them to not only to be competent, but also to know how to carry themselves in the age that we are in. It's not only directed to boys, but also to men. And in these, we talk about the importance of emotional intelligence, and also the importance of seeing a counseling psychologist when you need to see one. And men like me and plus other psychologists, we are trying to come out and say, listen, dear man, seeing a counseling psychologist talking about a problem, being vulnerable is a strength, because vulnerability is seen as a weakness, telling someone how you feel and think, the emotion that you're struggling with. So many men associate that with a weakness. We are trying to inform the men that it's actually a strength, and it's something that you can identify with, and it's something that you can pass on to your sons.
Dr. Gitahi, there's a question here for you from online saying there's a need for infrastructure, tech-based, need for clear communication between governments, population, companies that will build trust. The question is, having worked in an organization that has a bird's eye view, not just of Kenya, but of Africa, what is the maturity level of the country to create the social inclusion that, in a sense, is the basis of health?
Yeah. This is a really loaded question. And it goes back to the issue I talked about social justice. That ideally, we have seen that as globalization and inequality increases, mental health challenges increase. So actually, globalization is a cause for increased mental health challenges, because most of the things that we have, especially when you're talking about even the fourth industrial revolution of technology and the use of technology and technology taking over lives, one of the things that I'm sure Dominic would confirm is the difference between people's expectations and people's reality is one of the biggest causes of incongruence and the causes of mental illness. Now you have a world which is increasingly becoming divided between a very small number of people who have and a huge number of people who don't. And yet these two are then in one homogeneous communication space. When I grew up, I had no idea that people own cars. I thought cars are only for public transport. And I never had to know that because the radio never talked about it. There was no TV. It's only when I came to the university, I'm like, oh my God, people actually own cars. And therefore I started having the dream I should own one myself. But now you're living where a child who is living in a community or in a household where they have absolutely nothing, they don't even have food to eat, is also on social media and seeing other children flying to Dubai, you know, eating bacon every morning. And this incongruence, you know, what we call that, you know, dissonance, is a big cause of mental illness. So it is important and imperative that social inclusion becomes the principal driver of our economies, that our economies, which have been so heavily market driven, of if you have, capitalistic, if you have, it's okay, if you don't have, you will have someday, they need to reverse this trend so that we start to see that principles of social inclusion, like social protection, for example, social welfare states, social welfare communities, principles like universal health coverage, that are equalizing people at a basic needs principle, are so critical to the future of this, you know, of this world, that they need to be the drivers. We've seen now people talking about post-COVID. We are going to see now, I think I saw the CEO of Twitter, for example, say he's going to put money in the response of COVID-19, but he'll also put some money in investigating a principle which has been there for some time called universal basic income, which was talked about earlier by World Bank. It's kind of limped along, but right now, with the disruption that we are seeing with COVID-19, with the mental illnesses that we are going to see during COVID-19 and post-COVID-19, because of the economies crashing, people losing their livelihoods, people losing everything they had, that you have to revisit the issue of equalization. That the fact that I have and you have doesn't mean that we have that by right. You know, we are living in an economy, in a country, in a geography that then has an equalization mechanism called tax, that must then look at that and say there are some basic needs which we all share, and that some of those include health and universal basic income, which is basically saying anyone who doesn't have anything requires a basic level of income, even if it's $30 or $20 a month, and that is given as a right, is going to be one of the ways of preventing mental illness, and is what we talk about social inclusion. So we must revisit the social inclusion as we look at how the future markets are going to look like.
Absolutely. And Dominic, because that kind of brings me to the question of how the pandemic will further exacerbate that same issue that Dr. Gitahi was talking about of social inclusion. It has not been a priority in our country, clearly. And so now what this pandemic is doing is laying bare those inequities and the need to respond. So what's the impact, the mental health impact, if that doesn't happen, because the pandemic is further exacerbating that situation?
Sorry, I want to thank Dr. Githinji for mentioning this, because one of the things that we actually have to understand is, whereas the pandemic itself was unseen, the consequence of the suffering that we are suffering is because of social injustice. It's a big part on that. So we have to understand that where we are right now is about damage control. We are at damage control level. What's it that we can actually salvage? So now, many psychologists will explain to you that economic, they released allow me to, they released a happiness level of countries around the world, and you could see the strong correlation between the countries that registered high levels of happiness with economic strength or economic social justice, if you use that word. Now, so what is going to happen? Now, because of COVID virus, economy has been slowed down. And we are saying there's a relationship between a weak economy and higher levels of mental illness. So we can actually see that there is going to be an increase in mental health issues. And some of these, again, it's about loneliness and isolation. And here it's an interesting thing to explain, and I use this longitudinal study a lot because it helps to explain that Harvard University accompanied 268 men from 1968 to now, only around 18 now are alive. And that time Harvard University was only an all-male university. And they wanted to find out what makes for human flourishing. What is the one thing that makes for people to be happy, to thrive, and to live long? And so there was, of course, the question of genetics, social status, social class. But at the end, the biggest predictor of human flourishing was found to be the relationships that one keeps. And one of the things that they found out in that is, if you're in a bad, let's say a bad relationship, a bad marriage, and then you're having a physical illness, you're going to experience twice as much pain as someone who is in a good relationship or a good marriage. So that's a fascinating, anecdote there. And also people who are single, people who do not have people who they can talk to, a confidant, someone who they are close to, also have a higher death rates than a general population of those who have a relationship and people they can talk to. So loneliness is going to be a problem, especially for those people who do not have someone to be with, maybe because the person who used to visit them cannot visit them any longer, they cannot go to see that person, or they are staying with people maybe they do not like. Take, for example, you can imagine a young person who wants to stay in a family that is abusive. So we are also going to see this. So coming from this loneliness and abuse and all that, we are going to see higher losses of meaning in life. People are going to report losing meaning in life. I was a provider. I am no longer able to provide for my family. I had a job. That job is gone. I had the relationship. Those relationships are gone. Today, I was speaking to one person who was actually fired yesterday, even though they were a very good performer for the organization they were working for. They were asked to leave, and they are suffering for it, at a very serious level. So to deal with that, we are going to see higher levels of substance abuse. I was talking to a wine and spirit shopkeeper as part of my curiosity as a psychologist, and he was telling me how much alcohol is being bought, and in bulk, that people are going to drink more than usual in order to deal with the issues that they are facing right now. Now, that is itself as a mental health condition. And what are the conditions that follow when people abuse drugs? Physical illnesses that are going to come because of people abusing drugs. So we also have to deal with that. So, and finally, one thing that I mentioned when we're having this conversation also is the question of survivor's guilt. People are going to suffer about survivor's guilt. Why did I survive? Why did I not lose a job like everybody else? Why was the fact that someone lost a friend and I didn't lose anybody? So there's a question of survivor's guilt, and it's a real problem as far as one can tell. So it's something that we need to deal with and to process and to see what we can do. Other issues will be when people go back. Many companies will try to see what they can do to cover on that time that they lost. So they'll put a lot of pressure on their workers. This is going to result to higher levels of depression and duress in workplaces as people trying to catch up for the time that is lost. So we need to understand that all this will happen, and what we can do is what we are doing right now: help people understand, give them coping skills that we discussed before, making sure that you're moving every day, that you're not sitting for too long, making sure that you're eating well as much as you can, and cut down on coffee, cut down on sugar, cut down on salt, cut down on carbohydrates, especially if you have a mental health issue, and you do away with the coffee, do away with the coffee, do away with the alcohol, because alcohol is an it's an anti-inhibitor, which makes you lose sleep. One of the most important sleep is called REM sleep, the rapid eye movement sleep, which is usually removed when you are high or when you drink alcohol. So helping people with coping skills like this, I hope, in my opinion, will help people deal with that particular evil or the issue of the pandemic that they are facing.
Dr. Gitahi, there's a question here from one of the viewers to your earlier point. They're saying the economic incentives of government may become a problem in our continent as there are many corruption cases. Does the government of states are open to provide an open data to enable more transparency, to facilitate what it is you were talking about earlier?
Yeah, and I think one of the things which we really need to improve on and to work on across Africa, it's been successful in some sectors but not all, is civil accountability and social accountability, people's ownership. If you look at the movements of emancipation and the rise of accountability in some of the countries in the West, it was driven by people. You know, it is people who drove the Black Rights Movement, it's people who drove the end of slavery, it's people who drove. So this is really critical. And I think for ourselves, we also need to see how do we improve institutionalization and resourcing of civil movements and civil accountability so that people are informed. If the government is going to launch an economic rescue package, there should be somebody within the civil society who understands budget advocacy, who understands what an economic rescue is. Most of these will normally go through parliament. You know, any expenditure goes through parliament. Even now, you know, in Kenya specifically, we've seen the president announce a raft of tax measures that are going to help Kenyans go through these challenges. They have to go through parliament. They're documented. Now, but the challenge is that other than what we see on the headlines in the newspapers, very few people in our civil space will then pick that, look at the documents, look at what was actually in whatever was passed in parliament, and then monitor, and then hold the government accountable. So this is what I would like to say, that at the end of the day, we need to institutionalize people's accountability, and it is the people, you know, who will hold the government accountable. I like to say everyone has a boss, and the boss of government is the people. So I think most importantly is to bring the civil society side of accountability, because otherwise there's no other way of knowing. If the government says we release 6 billion and they give 3, there's no other way of knowing, you know, unless there is somebody providing data. That's the importance of data and information, and then somebody asking the right questions, and then using the media as a leverage for, as a tool for that. So.
And gentlemen, we have about 10 minutes to go in this session. One question here, someone asking, we're not the boss of life, uncertainty is real, health is precious, caring for each other is essential, wellness over disease management. What might be the relationship between the earth destruction and mental breakdown? And to that, Dominic, I want to add this as well, because there's also a psychological response to a pandemic as well. Some people have described this COVID-19 pandemic as a state of war, if you will. There's this common enemy that all these states are coming together in terms of resources and response to try and tackle. What does that mean in terms of the impact on their populations in terms of mental health, and how should they also psychologically respond? Because when you're thinking about roughly 2.3 billion people under some form of lockdown, that's a serious psychological experiment that we did not see coming. How do governments and other institutions psychologically respond to this pandemic?
Could you ask that question again from the viewer?
Yes, so the viewer was asking, what is the relationship between earth destruction, I guess environmental factors, and mental breakdown? Mm-hmm.
Okay, so this is a question that has been handled by religious myths that for millennia, and these days there's a movement in the psychology in studying religion. One of my friends, a psychology professor, psychology of religion, and he is interested very much in the question of and he's interested in the question of the religion plays in terms of psychological development. And I think there is a very important psychological truth here that has been hidden in so many religion traditions for millennia, for thousands of years. And this is this, that the more you engage in what is wrong, it corrupts your soul, right? And the more it corrupts your soul, the more you don't see, the more you harm not only yourself, but that which is around you. I think it's the whole idea that you might find in the book of Genesis, that the moment that Adam and Eve sinned, they not only suffered, but also the earth started, growing thorns. There is a very important, of course it's a religious connotation, but it gives us the language that we need to explain this insofar as I'm concerned, that when people constantly engage in what is wrong, in what is sinful, let me use the word sinful here, and I use it from the etymological source. The word sin comes from the word Greek, which is to miss a mark, and which is to miss the mark, that you are aiming for a certain high ideal, and when you have missed that mark, the Greek terminology for that, which has become part of religious terminology, is you have sinned, you have missed the mark. So this is what I would say. The relationship that I would see between people and harming the environment is, I think we have created a habit of greed, of what Dr. Githinji was saying, that we live in a world where, you get what you can for yourself. And if you don't get, well, get rich or die trying. And if you die, it's up to you. that we actually define people by their worth, that there are actually people who are called high net worth individuals, that is your worth is by how much you actually own, and you have nothing, you are more of a liability. So this is my connection, that there is a connection between the soul, the essence of a human being, that gets corrupted by doing what is wrong for so long, that they start also harming the environment, where the place where they live in, as a consequence of this corrupted soul. So this is what I would mention, using more or less a religious language there. Now, coming to the second part of the question, what can governments do? What I hope is people will not let government forget about social structures, that people will wake up and put more pressure on governments to deliver, to make sure that the social structures are actually at the service of the human being. You know, we need to have a discussion, and we need to close this debate that when it comes the question of profit versus people, that people have to win. But right now we live in a world where we say in words that it is people over profit, but the way we engage our world is profit over people. So this is a very important point, to actually reorient our social structures to the service of human beings. I was very impressed in the discussion that we had, especially the nominated Senator Kasanga, at least here in the Kenyan context, where she is proposing to amend for the amendment of the 2018 mental health bill, so that we can deal with the systemic issues that about mental health, about mental illnesses, that we can deal with the systemic issues. That what Dr. Githinji was mentioning, that mental health care is not seen as a secondary health care, but as part of primary health care. So that also doctors can realize that possibly a good percentage of the somatic illnesses that they're dealing with are actually psychosomatic illnesses. So when they understand that, possibly we can move forward. And for us as psychologists and professionals, we continue with the work we're doing, advocating, creating awareness. I do a lot with some other psychologists, training parents on how to actually understand their teenagers, like adolescent psychologists, to understand what is happening in their lives themselves. So that when we train the primary caregivers, teachers and parents, they can actually accompany huge population of people in terms of the children that they accompany. So this is what we are doing as counseling psychologists. And we know the impact of spiritual leaders, at least in the African context. And therefore we are encouraging pastors and priests, to refer cases that are clearly, psychological, or at first to refer some of the people they accompany to see a psychologist, so that the psychologist maybe can rule out that this is not a psychological issue, and it's a question that needs accompaniment by a counseling psychologist, or at least a pastor. And also we are helping people who deal with people to have basic counseling skills. We have been going to schools and institutes of higher learning to teach, to open peer counseling groups, so that students can accompany each other, at least with basics of professionalism. So this is what we are doing, and I hope counseling psychologists, wherever they are, we can continue to work to this direction, and that there'll be a structure within Kenya that actually has teeth in terms of the structure of psychology. We don't have that at the moment. In the meantime, we have organizations like Kenya Psychological Association, but they are not administratively strong in helping to have SOP or started operational procedures. Yes.
Dr. Gitahi, the last word goes to you, and I'd like you to speak, as you make your closing remarks, to the fact about funding when it comes to mental health care in this country. It's heavily underfunded. How do we fix that issue and attract more funding to that segment of healthcare to show that the government is in fact taking mental health in this country seriously?
Countries are moving away from supply side funding or supply side financing. Supply side financing assumes that you know all the needs of the people, and you put a budget line and a vote on them, and then you send the money to the health system, and then you expect that you have covered everything. And then you end up leaving areas like mental health, and that's what has happened for a long time. And there are many other areas that have been left out. In fact, not only in financing, but even in the architecture of the health system. If you go to a dispensary now or a health center, there's no recognition of chronic disease. It's assumed, for a very long time, it was assumed you go there because you have an acute need, you're treated and you go away. So when you record that Victoria was here because she had a cough, they just record you came and you went. If you come again because the cough was chronic, they record it as another visit, because there's no process of recording people who have chronic ailment. And that's the same thing with mental health. that actually because these non-communicable or chronic illnesses were never planned for. It's therefore missing in the total health system. So what we are moving towards is demand side financing, where you as an individual seek what you need and you have a card through a national health insurance fund, and it is available to everyone. And for all the people who can afford, it is funded through taxes. So that all the poor, in Kenya or any other country, will get a government funded card, and those who can pay, like you and I, then buy for ourselves. That's how we are moving to, in which case we do not have to advocate for vertical financing, that please finance mental health, please finance this. You finance a package that's inclusive and conclusive for everyone, and that is people-centered, and then don't have to worry about what's going on. Right now, even if you look at, if we can come up this conversation and then go on to another webinar on cancer, and they'll also be saying, oh, there's not enough money for cancer. So we want to move away from this vertical funding to people-centered funding that is demand-side finance, that is actually accessible to all for all essential services, including mental health. And that's where we are moving to.
Thank you so much, Dr. Gitahi and Dominic, for your time. Great insights there when it comes to mental illness in this country, on this continent as well. And hopefully it's no longer a silent epidemic, that we can come out and have more conversations like this to break stigma. And that does it for the Boma Kenya session. Thank you so much for watching, for your questions and your feedback as well. We'll always appreciate that. The next session, we'll be going to directly streaming from Qatar, and it will be led by Anwar Dafa Allah. The session will be in Arabic, and after which we'll have Boma Poland, which will continue the conversation in English. Stay tuned. Thanks for watching. I'm Victoria Rubadiri. Over to you, Anwar.
Hello. Thank you very much, Victoria, Marconi, and everyone for hosting this fantastic session. Now going to stream live from Qatar, where I'll be joined by Dr. Rashid Diab from Khartoum and Dr. Yassine Gaddal from Khartoum as well, and Dr. Iman Saeed from Qatar. Our session will be titled Mental Health, the